Um, so on February 22nd, in this really remote gold mining town, a single coffin was burned.
Right.
And within just 2 weeks of that, dozens of people were dead. But the broader world, the international community, they wouldn't actually sound the alarm for
Yeah.
almost 3 months.
Yeah, it was a massive delay.
Welcome, everyone. I am genuinely so glad you are here with us today. We are going to calmly and deliberately examine the current global health situation surrounding the 2026 Ebola outbreak in the Democratic Republic of Congo and Uganda.
It is so important that we take our time with this today.
Exactly, because hearing the word Ebola, it is inherently frightening. It carries this heavy emotional weight and immediately brings up these really alarming images.
It absolutely does. It's a very loaded word.
But our goal today, together with you, is to just set aside that fear. We're going to take our time, explore this thoroughly, and understand the actual practical risks.
Right, because panic doesn't help anyone. Critical thinking is really our best tool here.
It really is. So we will look closely at the clinical reality and the global response, totally without giving in to panic. We have all the time we need to just walk through the facts together.
Okay, let's unpack this. The timeline of those early months really unlocks why the situation right now is so severe.
It's the key to the whole thing, honestly.
Yeah, because the global community officially declared a public health emergency of international concern on May 17th. But the spread, it was happening completely undetected in the shadows long before that.
Yeah, that gap between February and May is the critical window. If we look closely at that specific event in Mongwalu, which is a very remote gold mining town in the Ituri province, we see exactly what happened.
Right, the coffin incident.
Exactly. The moving of a body from a local morgue and then the subsequent burning of a coffin in late February, it created this textbook cluster of transmission. Dozens of people passed away shortly after.
Just from that one localized event. Yes. Yet it remained entirely off the radar of the broader surveillance networks. The virus was able to just firmly entrench itself in the community while the world was essentially looking the other way.
And the delay wasn't just because the town is geographically isolated, right? There was a fundamental biological blind spot at play there.
There was a massive diagnostic failure, yeah.
Because local medical staff and community leaders, they initially suspected tuberculosis, which, tuberculosis is incredibly common there. It is deadly, and the early symptoms look remarkably similar.
They really do. A fever is a fever in those early days.
Right. But they did actually try to test for Ebola during those early weeks. It's just that those early tests simply came back negative.
And that is where the biology tricks us. Because diagnostic tests are incredibly precise instruments, but that exact precision is why the system failed in this specific instance.
How so?
Well, think of a diagnostic test as like a barcode scanner at a grocery store. The scanner is programmed to recognize a very specific genetic barcode.
Okay, that makes sense.
So the early tests deployed in that region were programmed to scan for the Zaire strain of the virus, which is, historically speaking, the most common in that area.
But the virus actually causing this outbreak is the Bundibugyo strain.
Exactly.
It has a completely different genetic barcode. So the medical staff are scanning these samples over and over, and the machine is just reading blank.
It sees nothing.
It is like looking for the wrong suspect in a police lineup while the actual culprit casually walks right out the front door.
That is exactly what happened. And by the time the correct testing parameters were finally put in place, and the true nature of the Bundibugyo strain was identified in May, the chains of transmission had been multiplying for months.
Wow. Months of undetected spread.
Yeah. In epidemiology, time lost is transmission gained. Identifying the exact genetic strain is the absolute foundation of stopping an outbreak. It dictates literally everything, from the specific tests you deploy to the vaccines you use and, the treatment protocols you follow.
And because those crucial early months were lost to a scanning error, we are seeing some really troubling models now.
We are.
There are at least 60 confirmed deaths, but retrospective investigations suggest there could have been 100 or even 200 deaths before late May.
Which is staggering.
It really is. We are looking at scenarios that could potentially surpass the devastating 2014 to 2016 outbreak in West Africa.
And that is why understanding the mechanics is so vital.
Right. Hearing how entrenched the virus became makes the mechanics of how it spread so crucial to understand. We really need to be precise with our language here, especially regarding how a virus actually moves from person to person.
Language matters so much in public health.
It does. People use the words contagious and infectious interchangeably all the time, but biologically, they describe very different threats.
They do. So a contagious virus like COVID-19 or the measles, it spreads incredibly easily through the air. You can catch it just by sharing the same breathing space in a grocery store or an elevator.
Just casual contact.
Right, casual contact. Ebola is not contagious in that airborne, casual way. It does not spread through casual contact, but it is exceptionally infectious.
Meaning it takes almost nothing to cause an infection.
Exactly. It requires only a microscopic amount of bodily fluid to enter a person's system. However, it only spreads from someone who is already profoundly sick.
So they have to be showing severe symptoms.
Yes, the biology of the virus requires a massive viral load to build up in the patient's system. And this usually happens about a week or so after their initial infection. Before that high viral load is reached, they simply cannot pass it on.
That biological reality completely dictates who is actually getting sick right now. I mean, the demographics of the patients tell a really heartbreaking story.
It really is tragic when you look at the numbers.
Yeah, because the people most at risk are the ones physically caring for the sick. The data shows that the majority of the patients currently are women between the ages of 20 and 39. These women are the primary caregivers in their families and their communities. They're the ones bathing their sick relatives, cleaning up fluids, and providing comfort.
And their compassion places them directly in the line of fire of this highly infectious pathogen.
It's just devastating.
It is. And the frustrating part is that personal protective equipment, simple masks, gloves, and gowns, can entirely prevent this type of transmission.
If they only had them.
Exactly. The tragedy is that the Democratic Republic of Congo is facing severe, compounding logistical hurdles. The region is dealing with violent, ongoing conflict, which creates mass displacement and extreme insecurity. Hospitals are entirely overwhelmed.
They just don't have the supplies.
No, for weeks there was simply not enough protective equipment reaching these remote clinics. You can understand the mechanics of the virus perfectly, but if a healthcare worker or a family member does not have a basic pair of latex gloves, that knowledge cannot physically protect them.
Right, because a microscopic break in the skin around a fingernail is literally all the virus needs to enter.
That's all it takes.
Hearing how highly infectious this is makes the low contact tracing numbers terrifying. If we know exactly how it spreads through direct contact with fluids, why is it so incredibly difficult to just track and trace the exposures?
What's fascinating here is how the biological nature of the virus collides head-on with the sociological history of the region.
Okay, tell me more about that.
Well, an outbreak is never just a medical problem. It is fundamentally a human behavior and trust problem. We have to look at the lived experience of the communities in the DRC. This is an area that has experienced decades of violent conflict and institutional failure.
Right.
So, when outside aid workers suddenly arrive in what look like spacesuits, telling you to leave your home and go to an isolation center, a deep, historically rooted mistrust just naturally kicks in.
It is a completely rational response based on their history with outside intervention.
Absolutely.
And furthermore, some community members genuinely do not believe the virus is real, or they see hospitals as places where people are taken when they are sick and simply never return. So from their perspective, the hospital just looks like a death trap.
Exactly. And if you believe the hospital is the actual cause of death, you will naturally hide your sick loved ones to protect them. You will actively evade the contact tracers.
That makes perfect sense.
And you will continue to perform traditional burial practices, which involve intimately washing the body, thereby further spreading the virus. You simply cannot trace a contact who is actively fleeing from you out of sheer terror.
So building community trust is just as critical and often much harder than delivering pallets of medical supplies.
It's the hardest part of the job, hands down.
Knowing how immense the difficulty is in stopping the spread in these remote, cautious communities, we really need to look at the clinical reality. Like what actually happens when a patient is successfully brought in for medical care.
The clinical progression is very distinct.
Right, because the tricky thing about this virus is how it disguises itself early on. At first, you just get these dry symptoms, a standard fever, general achiness, profound fatigue. It looks like a dozen other common illnesses.
It really does. It mimics malaria or the flu.
But then, as the viral load explodes, it shifts into the terrifying wet symptoms. severe diarrhea, vomiting, and unexplained bleeding.
Yes, and that transition to the wet phase is the critical moment where the body enters a profound crisis. The virus actively attacks the vascular system, essentially causing the blood vessels to leak.
Just leaking fluids everywhere.
Yeah, this rapid, massive loss of fluids leads to hypovolemic shock. The blood volume drops so low that the heart literally cannot pump enough oxygen to the vital organs, and the organs just begin to shut down one by one.
Here's where it gets really interesting, though. When we think about fighting one of the world's most terrifying pathogens, we immediately picture, billion-dollar biotech, high-tech laboratories and complex chemical compounds.
Yeah, cutting-edge science.
But the most life-saving intervention is actually incredibly simple. It's basic fluid and electrolyte replacement. Our greatest weapon against this virus isn't always an experimental drug. It is salt and water.
It's incredible, isn't it?
It is. If a patient is brought in early enough, just hooking them up to an IV, pumping them full of fluids, and managing their blood pressure can absolutely save their life.
It is a profound testament to the power of supportive care. And we have to remember the underlying mechanism here. We aren't directly killing the virus with those IV bags.
Right. The water isn't fighting the virus.
Exactly. What we are doing is buying the patient's own immune system the critical time it needs to mount a defense. By constantly replacing the fluids that are leaking out of the vascular system during those severe wet symptoms, we prevent organ failure.
Keeping the engine running, basically.
Yes. If we can keep the body's infrastructure from collapsing for just a few days, the human immune system will often successfully clear the infection entirely on its own.
Wow. We are, of course, still racing toward those high-tech solutions to give the immune system an even bigger advantage, though.
Oh, absolutely.
Like, we have the case of Dr. Peter Stafford, an American missionary physician who was infected in the DRC and evacuated to Germany for treatment. He is receiving experimental monoclonal antibodies.
Which is fascinating technology.
Yeah, think of monoclonal antibodies less like a targeted missile and more like gum in a keyhole. They bind directly to the spikes on the outside of the Ebola virus, physically gumming them up so the virus cannot unlock and enter healthy human cells.
It is a brilliant biological defense. But these antibodies are still experimental for the Bundibugyo strain.
Right.
And this really highlights the tragic consequence of the testing failure we discussed earlier. We actually have an approved, highly effective vaccine for Ebola. It was developed and successfully deployed during the West Africa outbreak. But it targets the genetic barcode of the Zaire strain. Because we are dealing with Bundibugyo, the existing vaccine is completely useless, and we are essentially starting a new race from scratch.
That is so frustrating. And the vaccine timeline is incredibly frustrating right now, too, though it is progressing. Moderna and a joint effort between Oxford University and the Serum Institute of India, they have vaccines that might be ready for clinical trials in 2 or 3 months.
Which is fast, but still feels like a lifetime during an outbreak.
Right. And another candidate from IAVI is at least 7 months away. Some of these candidates don't even have animal testing data yet.
Yeah, it's very early stages.
However, there is a priority oral antiviral candidate called obeldesivir. The mechanism here is different from the antibodies, right? The hope is that this pill could be offered to contacts of confirmed cases within just a few weeks.
Yes, the mechanism of obeldesivir is distinct and honestly very promising. While monoclonal antibodies block the virus from entering the cell, an antiviral like obeldesivir works inside the infected cell.
Oh, I see.
It essentially jams the machinery the virus uses to copy its own genetic material. If the virus cannot replicate, the viral load stays low, the patient doesn't develop severe symptoms, and crucially, they become much less infectious to others.
Imagine the power of handing a pill to someone whose husband just tested positive.
Yeah.
It prevents the virus from taking hold in her system. That changes the entire landscape of contact tracing.
It changes everything.
If people know that interacting with health workers means receiving a protective medicine that keeps them safe, rather than just being hauled off to an isolation ward, trust will increase exponentially. It completely alters the incentive structure for a community living in fear.
It shifts the narrative from isolation to active protection. When public health measures align with the immediate visible well-being of the individual, cooperation just naturally follows.
So what does this all mean for you, the person listening right now? We know an American doctor has been infected and evacuated across international borders. And we also know that right now, millions of people are traveling across North America for the 2026 World Cup.
It is a lot of movement.
It is totally natural to feel a sudden spike of anxiety. So if I'm at a World Cup match and the person in the seat next to me is sweating and coughing, my first thought might be Ebola. But based on the biological reality we just discussed, that's the completely wrong thing to be afraid of, right?
If we connect this to the bigger picture, the assessment from global health authorities is incredibly clear. There is a near zero chance of this becoming a global pandemic.
Near zero.
Yes. Your instinct about the coughing fan at the stadium highlights the exact disconnect between our fears and the biological facts. As we establish, a person is only infectious when they are exhibiting those severe, debilitating wet symptoms with a massive viral load.
Right, they're incredibly sick.
Simply put, a person sick enough to spread Ebola is physically incapable of attending a sporting event. They are bedridden, fighting for their life. They are certainly not waiting in line for a hot dog or navigating a crowded stadium.
The reality is, when we attend massive global events, the true threats are remarkably mundane. The real enemies are the things we completely forget to worry about. Extreme heat, severe dehydration, and the run-of-the-mill stomach bugs that always circulate in massive crowds.
It's the boring stuff that gets you.
It is a profound irony. We spend enormous amounts of mental energy worrying about an exotic, terrifying virus crossing borders, when simply forgetting to drink water in the summer heat is the actual statistical danger facing fans at the World Cup.
It is entirely human nature to fear the dramatic and ignore the familiar. But that human tendency is exactly why we have a global public health infrastructure that operates on cold, hard data rather than emotion.
Thankfully.
Yeah, and that infrastructure is very actively monitoring this exact situation to ensure global safety. The United States has already implemented highly specialized airport screening protocols. If you are traveling to the U.S. and have been in the DRC, Uganda, or South Sudan within the previous 21 days, which is the maximum incubation period for the virus, you cannot simply fly anywhere.
They route you.
Exactly. You are actively routed to specific funneling airports. Atlanta, Houston, JFK in New York, and Dulles outside Washington, D.C. are all equipped and staffed to conduct rigorous health screenings upon arrival.
And the safety net extends far beyond the border screenings, too. There's a brand new Health Security Operations Center, which is a massive joint effort by Georgetown University and MedStar Health.
Which is a fantastic initiative.
Yeah, this is a collaborative intelligence hub that monitors potential infectious disease threats every single day during the tournament. They are synthesizing global data and distributing daily situation reports to hospital managers, local health officials, and tournament organizers. And the CDC is running its own World Cup data dashboard, tracking surveillance data in near real time across the country.
Responding to these types of complex, overlapping threats is the absolute bread and butter of public health professionals. We have been in exactly this position before, and we have the blueprint ready.
Like in 2014.
Exactly. During the 2014 outbreak, the U.S. successfully treated multiple Ebola patients in specialized, federally designated treatment centers like Emory University in Atlanta. Facilities like the one at the University of Nebraska are constantly maintaining their readiness.
They don't just sit empty.
No, they regularly use their biocontainment isolation rooms to monitor people for other severe pathogens, ensuring their staff and equipment are always prepared. The protocols have been rigorously tested, the specialized facilities exist, and the medical professionals are highly trained for this exact scenario.
Right.
The 21-day incubation period does mean it is mathematically possible that a traveler could arrive in the U.S. before showing any symptoms. But caring for those isolated cases did not lead to an epidemic in 2014, and it is incredibly unlikely to happen now, given the layers of surveillance.
We have spent our time today walking slowly through some very intense, very complex realities. We started our journey in a remote mining town, confronting a terrifying medical mystery, and we ended up looking closely at the gates of a crowded World Cup stadium.
It's been quite a journey.
As we wind down our conversation today, I want to leave you with a final thought to quietly mull over. Consider the invisible shield of the global health infrastructure. Even as you go about your normal day, perhaps sitting down in your living room to simply watch a soccer game, there is a massive, highly coordinated web of scientists, data analysts, epidemiologists, and medical professionals working silently in the background.
It really is amazing to think about.
They're tracking genetic mutations, developing new antivirals, and setting up complex screening protocols, all to ensure our collective safety. It is a profound, continuous testament to human cooperation and ingenuity.
Knowledge is always most valuable when it is understood calmly and applied rationally. The sheer volume of news and noise in the world can be deafening, but when we take the time to slow down, look at the biological mechanisms, and understand the facts, we find that there is usually a very steady, highly capable hand on the wheel.
The absolute best way to protect yourself and to protect the peace of mind of the people you love is to simply stay informed. Stay curious, stay calm, and keep seeking out the facts. I want to warmly thank you for choosing to spend your time with us today, for allowing us to guide you through this vital information, and for dedicating a part of your day to learning and exploring alongside us. Take care of yourself, stay hydrated out there, and we will talk again soon.